this is how it leads into advanced care planning, to the PEG tube discussion. Okay, which is something that the doctors, nurses and speechies are often having with patients. Now, very similar to the last talk, has to happen early. Okay, in terms of people making decisions about alternate communication, assisted communication. The PEG tube discussion is something I have, and I get involved very early with MND patients, usually shortly after diagnosis. And it's something I bring up early because when we used to wait, we didn't want to hurt their feelings, they're upset enough as it is. We'd bring it up when it was desperately needed. People would go like this, oh my God, what a horrible concept, let me think about it, and they'd miss the boat. Okay? So often good intentions, i.e. not wanting to hurt feelings, don't get good outcomes. So it is important that we deal with the unpleasantness of bringing things up early so that people can process the information and not end up back in emergency with acute, abdomen. So they haven't let themselves get to the point where it's unmanageable without a PEG tube. Or if they have, they've done that in an informed manner and they've decided this is the path I'm going to take and these are the interventions I'll accept and won't accept, and these are the strategies I'm going to take to make sure my quality of life physically and emotionally is reasonable. But they don't have that opportunity. We're not giving them that opportunity if we're mollycoddling and not getting in there early, irritating them a bit, but doing it in as non-confronting a way as possible. But I don't think I've ever brought up the concept of PEG tube and hadn't had an expression like this or something similar with a patient, unless somebody's already done it before me, or, or they've read about it or something. But if it's, I'm the person introducing this concept, you're going to get this. And you just need to be prepared for it, and you need to just do it in as gentle a manner as possible, but not so gentle that it's not clear communication. Okay. So that's what moves on. We're doing really well. We've got plenty of time. So this is what moves on to advanced care planning. And you guys might be asking, why is a rehab physician bringing up advanced care planning? And many years ago I didn't. I used to hide behind the palliative care team and physicians. And often I had a very good relationship with these patients. I'd been seeing them for some time, dealing with fairly intimate issues with family and physical symptoms, emotional symptoms, and I asked a very experienced, really good pal care physician to come in and start talking about this with a patient. This is about 3 years ago, and the patient turned to the pal care physician and said, "Why should I talk to you about this? I've never met you before." And this is a really nice pal care physician. Yeah. And I thought, oh, see, I'm always trying to learn. These talks are more about me learning than you guys. That's why I want more comments. And I thought, that's a really good point. So I went off and did a course on advanced care planning and had a chat with the director of PAL Care here and where I work. And he was very much of the opinion that really advanced care planning should be done before, long before the terminal phase, long before it's important, and long before really PAL Care get involved. Although in our service, PAL Care get involved from diagnosis as well. I've made it, you want to see rehab, you see PAL Care. We do it together. Because we're having so many barriers to people accepting PAL Care that I just took the choice away and just added it in with rehab, so it was a package deal. Which has been good. It's had a much better outcome because you can only have so many skills and so much knowledge in one person, which is why we have multi and interdisciplinary teams. And in our multidisciplinary team, I guess we've got multiple medical. It's not just rehab. It's rehab, PAL Care, neurology. So you've already seen neuro and PAL Care, respiratory and gastroenterology, and they're all involved in our service type thing. So it's not just one medical profession, just like it's not just one allied health. It's a whole spectrum. So advanced care planning. So the only thing I can talk about is it's very individual, okay? Generally I have a rule, I don't bring it up the first time I meet them, although I was forced to in a clinic earlier this year because a patient came in, he'd been diagnosed like a week earlier, and I was a bit slow on the uptake. It was the third time he brought it up before the other person had said, "Shea, it's the third time he's brought it up. He really wants to talk about it." So I went there. I was a bit uncomfortable, but often the discomfort is more from us than the patient. Often they're sensing our discomfort, so they don't want to bring it up because we don't want to. And often when I have brought it up, it's been very well perceived. But I never use the phrase end of life planning or whatever. I use advanced care planning. I sell it as a way to stay in control, as to stay empowered, that they have control and ownership of their treatment. But again, don't worry, this is my last slide. You know, what is a good outcome? You know, it's very individual, like the one white flower. I've had patients first visit, they want to do it, they want to take control, they don't even want to talk to their family about it, it's them. I've had another patient who just said, I don't want intubation, I don't want resuscitation, I don't want any more discussion about this, every decision I want made by my husband and my son. Don't talk to me about it. And they did an advanced care plan to that directive, you know, so which is fine, it was clear cut. They didn't want to face it, but they were going to empower somebody else to face it. And just another quick point, what is a good outcome and for who? Again, I learnt something from, I can't remember who said it, it was one of my team, maybe they can put their hand up. We had a patient a couple of years ago who had a physically hideous death in the high dependency unit after third or fourth or fifth aspiration pneumonia. You know, this guy was almost locked in, he could only communicate with eye gaze. And, you know, we were always pushing for, you know, comfortable death, palliative care, but after he passed away, and his family, 2 minutes, all right, last slide, and his family were all, oh, I wish we'd gone to pal care, wish he'd had a comfortable death and that. And he had young children, and somebody told me, I wish I'd remembered who it was really important for him to die fighting. Okay, so that was his choice, he exercised it, he wanted to fight to the end, it was important for him to do that rather than have a physically comfortable death. Now that brings up a whole bunch of ethical questions, resource utilisation, what is appropriate, who's it a good outcome for, who are we treating, the patient, the survivors, ourselves, the healthcare budget, you know. So just something to think about.